Good evening, everyone. Myself, Dr. Madhukiran, Academic Head, Yashoda Hospital, Somajgoda. So, on behalf of Yashoda Hospital and Department of Emergency Medicine, I warmly welcome you all to today's academic session under Experts Appraisal in Emergency Medicine. We are delightful to have you join us for today's topic, ECG in Syncope, a highly relevant and practical subject that directly impacts emergency decision making. Syncope is a common yet challenging presentation in the emergency department, and ECG interpretation often plays a pivotal role in identifying life-threatening causes. Today's session aims to simplify this approach and highlight key ECG findings that every emergency medicine physician must recognize. It's my privilege to introduce our speaker for the evening, Dr. Malay Mishra, Head of Emergency Medicine at Yashoda Hospital, Secunderabad. Dr. Mishra brings extensive clinical expertise and academic expertise, and we are confident this session will be both insightful and clinically enriching. I would also like to acknowledge our leadership and organizing team for their constant academic support. Sir, over to you, sir.
Thank you, Madhukiran, for a nice introductions. We will start about this today's webinar. Today's topic for discussion is ECG in Syncope. As all the emergency physicians are sitting over here, like they are very much familiar with this term called Syncope. So this is one of the very cheap complaint in our emergency room with a broad differential diagnosis. And sometimes it is very benign, like just kind of faint symptoms, and sometimes it can go into acutely life-threatening emergency conditions. So often in your ECG, it is very important in your daily practices for emergency room physicians, and we will be like dealing with various aspects of ECGs. So I will be highlighting few important ECGs, how we should interpret and how it is going to relevant in our emergency room practices in a daily basis, and how we should take care of all those critically ill ECGs. Now going further, as all of you know, this syncope is very difficult to diagnose sometimes, and we can remember by mnemonics called ABC, ABCD left to right. So there are certain ECGs I am going to read right now so that you can recognize when the patient arrives to our emergency room. So one more term that is called transient loss of consciousness. So what happens when transient loss of consciousness happens? It can be as simple as I said, like very benign conditions, like faint kind of symptoms, and sometimes it can be a underlying disease that can be really life-threatening and which leads to sudden cardiac death. So as I said, syncope is not a symptom. It's not a diagnosis. So many of the times it is self-limited while having loss of consciousness and postural tone. Relatively, it is rapid onset with having variable warning signs and symptoms. It is very much spontaneous, complete, and usually prompt recovery without medical or surgical interventions in few of the cases. So we should always recognize what is the underlying mechanisms. The underlying mechanisms will be transient global cerebral hypoperfusions that will leads to syncope. So as you can see it here, this is a very important slides. So these slides describes what are the causes of true syncope, and you can see it in the left side. It is neurally mediated. It is very most common types of syncope what we encounter on a daily basis. Moving forward to the right side, it is called structurally cardiomyopathy changes. So the terms neurally mediated or neurally mediated reflex syncope or neurocardiogenic syncope all looks similar. Okay, and the conditions here, like I would like to mention here, is VVS, that is vasovagal kind of syncope. That is the most common findings in our OPD's room are concerned. Second is carotid sinus syncope. That is also very common, and some situational things like cough reflexes or post mixurational phase, you will have syncope. Moving forward, another one highlight thing is orthostatic syncope, particularly those patients who are already on diuretic support, drug-induced diuretics. So you'll have sudden decrease in blood pressure leading into syncope, and sometimes it might be ANS failure, that is autonomic nervous system failure, primary or secondary causes. Moving forward, another reason for the syncope is cardiac arrhythmias. Like as all of you know, our impulse starts from SA node, travels to AV node, and bundle of E's and Purkinje fibers. If some abnormalities happen in the SA nodal dysfunctions, you will have bradycardia and you will have some kind of cardiac arrhythmias related to the syncope. Second is AV blocks, like heart blocks like first degree, second degree, or third degree. Sometimes we'll have presentation for syncope. Then coming to the tachyarrhythmias like ventricular tachycardia, supraventricular tachycardia, long QTC syndrome, all these are responsible for cardiac arrhythmias type of syncope. Moving forward, which is least common, that is called structural challenges like any acute MI or any valvular diseases like aortic stenosis, hypertrophic obstructive cardiomyopathies, pulmonary hypertensions, and some aortic dissections. And in many of the cases, like unexplained causes are almost around 1/3 of the cases. So there is no reason why the person has heart syncope. We need to thorough examine the patients by looking at the ECGs. Sometimes we have to go for ultrasound, like that's the point of care device, POCUS, 2D ultrasound, 2D echo, to rule out exact true causes for the syncope. This slide says like there are many aspects where you will have a syncopal mimics, like someone has consumed alcohol, he is an intoxicated phase. You might feel that this person is unconscious, you will have syncopal attack. Sometimes seizure presentations also can mimic syncope. Sleep deprived, like someone has not slept for almost like 3 hours or 4 hours of sleep, that person might have syncopal mimics. Somatization disorders like psychogenic thing, trauma, concussions. Many of the times we may found hypoglycemia. It's one of the DD for stroke mimics as well. And hyperventilations, that is acute panic attack or anxiety disorders, hyperventilation syndrome. These presentations can have syncope. So these are all features for syncope mimics. Repeating once again, acute alcohol intoxication, seizures, sleep disorders, somatization disorders, trauma, concussions, hypoglycemia, and hyperventilations. Coming to the cardiogenic causes of syncope, so certain arrhythmias that I have already discussed, long QT syndrome, short QT syndrome, okay. Another one is polymorphic ventricular tachycardia, Brugada syndromes, whole Parkinson White syndrome. So these are all we will going to discuss in our next subsequent slides. Certain structural changes like hypertrophic obstructive cardiomyopathies, acute myocarditis, arrhythmogenic right ventricular tachycardias, coronary artery abnormalities, valvular aortic stenosis, and pulmonary hypertension. So these are the structural causes for cardiogenic syncope. So like we all knows, what are the methods or rules to read a ECGs? Like conventional one, we should always look for rate, then calculations of rate, then rhythm, then axis, then morphologies. Similarly, to rule out cardiogenic syncope, we have certain mnemonics that is called HEARTS. 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 H stands for heart rate and rhythm identifications. So whenever you see a ECG, make sure you can able to calculate the heart rate and the rhythm, like whether it is tachy or brady. Then comes E. E stands for electrical conductions. So you should always calculate AB block. If there anything is there, first degree, second degree, third degrees, can able to interpret. Then we can able to appreciate is there anything WPW like whole Parkinson White syndrome or any bundle branch block or any QTC prolongations that will able to identify when you are seeing a ECGs. Next comes A stands for axis. We should always make a habit of reading like it's a left axis or right axis. Then comes R wave. So if the R wave's amplitude is very small, we can say like there is fluid around the pericardial cavity or a lung. So we can keep it as tamponade effect, and we can there is a early R wave progressions and sometimes so repolarization effects. We may have to go for a little beyond, like to look for a RBBB pattern or a left bundle branch block or whole Parkinson White syndrome, delta waves, epsilon waves. We will be able to pick out of that. Then like postural MIs like posterior myocardial infarctions or pulmonary hypertension pictures. If it is there in the RAFs, you can able to appreciate. Then comes T. T stands for tensions. So like any structural changes like aortic stenosis or hypertrophic obstructive cardiomyopathy changes are there in the ECGs, you can able to appreciate that. Then comes STD changes. Here you can see a little advanced ECG like AVNRD, Brugada syndromes, MI, posterior MI particularly, and pericardial pleural effusions pictures also you can able to appreciate in the ECG. So this is the pattern you should read when you are looking at the ECG. You should go along with this heart, HEARTS, hearts. So moving forward to the cases, I have certain ECGs to show. First one is the 20 years old female, previously well with half an hour of palpitations and pre-syncope. Then it got resolved. So you can easily see it here. The heart rate, the rhythm, it is normal sinus rhythm. Electrical conductions, there is short PR interval here, short PR with this typical picture is called delta wave in precordial leads. Axis, we can see it by lead 1 and AVF. It looks normal. Both the directions of the RVFs are in same size, same directions. RVFs is early progressions, and there is no tension as like no structural damage. So STD changes like mild anterior ST depressions, you can see it here, and a discordant to delta waves. So you can easily remember this delta waves. It is for WPW, whole Parkinson and White syndrome. Moving to the next ECGs, there is a 80 years female recurring pre-syncope while sitting positions. Okay, you can read out these ECGs. It looks like bradycardia. 1, 2, 3, 4, 5, 6, almost heart rate is around 50. Then you can see easily calculate here the axis is lead 1 and AVF. Okay, this is opposite in directions, so you can call it as left axis deviations with RBBB pattern. Okay, and minimal voltage criteria like that is Sobolev or Lyons criteria. It is called LVH. So this looks like a abnormal ECGs. So here, what is the classical pictures here? Can able to say the heart rate rhythm is still sinus bradycardia. Electrical conductions is like first degree heart block with RBBB pattern and left anterior fascicular block. The axis is left axis because of left anterior fascicular block. R waves, you can see it as early right bundle branch block, and STD changes are not so much significant. So diagnosis here is bifascicular block, like first degree heart block with RBBB pattern. Okay, so this patient is admitted for pacemaker, right? And there's another case. This is looks like 25 years old male with exertional syncope. So here you can see this ECG evidence of what? This left ventricular hypertrophy. You can see it here. After a syncopal episodes, raises concerns of like for impaired cardiac outflow. Okay, so how do you know it's a LBH pattern? Like there is a criteria called Sokolov or Lyons criteria. It is very, very well accepted criteria to diagnose LVH pattern. So you can see it here, the sum of S waves in V1 or V2 plus R waves in V5 or V6. If it is greater than more than 35 millimeter, is one of the most widely accepted criteria to diagnose LVH pattern, left ventricular hypertrophy. So like I said, we're going to the same mnemonics, hearts. H stands for heart rate. You can say it's tachycardia. Okay, E stands for electrical conduction. It is normal. Axis is normal. Then look at the R waves. It is large voltage with deep inferolateral Q waves are there. Here you can see the Q waves in the lead 3, lead 2, lead 3, and lead AVF also. And these structural changes, there is left ventricular strain pattern, LVH pattern. STD changes, there are no much significant. And in the 2D ultrasound, 2D echo, you can say it's hypertrophic obstructive cardiomyopathy changes. Okay. Moving to the next ECGs, there is a 70-year-old female with history of cancer, malignancies in the background, presents with shortness of breath, and like immediately after obtaining the ECGs, patient suddenly got collapsed. So you can see it here. The ECGs, it is called low voltage ECGs, right? The amplitudes are very, very low. Okay. So looks like sinus tachycardia. The electrical conduction systems looks normal. Every P followed by QRS complexes. The axis also looks normal. Okay, but only the change is the R waves. The R waves are very small voltages. Okay, so like STD changes, there are no significant changes. In 2D echo, you can see there is RARV dilatations. Okay, RV is more than LV, and the patient arrested, ROSC is achieved after this TPS, tissue plasminogen activator, and CT scan showed massive pulmonary embolisms. Okay, so you can see it here, like low voltage ECGs will have this. Another one case, 70-year-old male, he is unwell. After ECG obtained, patient suddenly collapsed. This is a history. So how we want to proceed this case? So this looks like Brugada syndromes. Okay, it's a channelopathies, sodium channelopathies developed by the Brugada brothers. Sorry, Brugada brothers. So you can see it here. ST coped segment, coped ST segment more than 2 millimeter of elevations in V1 to V3 with a negative T wave inversions. So this is one of the most common cause of sudden cardiac death in young patients. So what is the treatment here? Implantable cardiac defibrillator. Okay, if implantable cardiac defibrillator are not available, so you can go with the quinidine. Quinidine has been proposed by an alternative method when the settings where ICDs are not available. Coming to the types of Brugadas, there are 3 types: type 1, type 2, and type 3. In type 1, you can see it's called coved ST segment elevations more than 2 millimeter in V1 to V3, followed by negative T waves. Remember, this is the only ECG abnormalities that is potentially diagnostics. Okay, coming to type 2 Brugada, it has more than 2 millimeter of elevations with saddlebag shaped ST elevations. So remember, in type 2, you'll have more than 2 millimeter of saddlebag shaped ST elevations from V1 to V3 leads. And in type 3, it can be morphology of either type 1 or type 2, but with less than 2 millimeter of elevations ST segment. So remember, type 3 it can be of type 1 or type 2, and the elevations will be less than 2 millimeters. Okay. So coming back to the ECGs, the heart rate or rhythm, it is normal sinus rhythm. Electrical conductions, you can see it here, easily appreciated. This is right bundle branch block. Axis is normal. R wave, there is normal size or no progressions. Structural changes, it's not there. STT changes like V1 to V2, you can see it here. Like I said, there will be curved ST elevations. And diagnosis here is Brugada. So patient had ventricular fibrillations, arrest immediately after opening the ECGs, and cardioverted, admitted to ICU for implantable cardiac defibrillator. Moving forward, there is another ECGs. There is a 60 years female complaining of chest pain. Then she had syncopal attack. So you can easily appreciate here, there are certain changes like there are T wave inversions. You can see it here in V1, V2, and V3, particularly V2, V3. Okay. So this signifies what? Posterior wall MI. This is a mirror change. If you can reverse the ECG paper, you can see it here. There will be ST depressions in V2 to V3. So if you just reverse the ECG paper, you can able to see there are ST elevations. So when there is tall upright T waves, you can easily see T wave inversions is there, and the broad R waves will become the Q waves. So around 15 to 20% of all STEMI, ST elevations MIs, accounts for posterior wall MIs. So usually occurring in the context of inferior or lateral wall changes. So you should teach your nursings or technicians when they're obtaining the ECG, they should take for a right side ECGs. Okay. So V7 particularly, they should keep their V7 at the left posterior axillary line in the same horizontal plane as V5, V6. In V8, tip of the left scapula. Make sure you should teach them how to put the leads, and V9, left paraspinal regions. So like I'm repeating once again, for V7, make sure they should put the lead on left posterior axillary line in the same horizontal plane as V6. V8 at the tip of scapula. V9 at the paraspinal regions. So that you can get the right side ECGs. Coming back to the ECGs, so heart rate or rhythm, it is sinus bradycardia. Electrical abductions, it is normal. The axis looks normal. R waves, there are normal size. no ROA progressions. Tension, like there is no structural changes. But STD changes, there are anterior ST depressions with T wave inversions. If you reverse the ECG paper, you can able to see the changes for the posterior wall MI. Moving forward, there is another ECGs. 20-year-old man with palpitations and syncope. He is hemodynamically unstable. Elder brother, he died of sudden cardiac death at the age of 28 years. Any clue for this ECG? This happened after post cardioversions, right? So you can easily appreciate here. There are two waves, prominent waves. It is called epsilon waves. All right. So what are the significance for this one? This is the second most common cause of sudden cardiac death after HOCM. Okay, that is the first most common cause of cardiac death. After HOCM, this is the second most cardiac cause for sudden death. Okay, and that accounts for almost 10 to 15%. And this are antiarrhythmics and anticoagulants. That is a mode of treatment for this. Okay, and sometimes you may go for radiofrequency ablations RFA and implantable cardiac defibrillator. That is the only treatment available for this arrhythmogenic right ventricular dysplasia. You can easily appreciate here, these are called typical epsilon waves. Okay, and this mainly you can see it in the chest leads V1 to V3 in the absence of RBBB. Prolonged S waves of strokes, that also you can be seen in V1 to V3. Localized widening of QRS complexes and paroxysmal VT with left bundle branch block morphology with ventricular ectopic sometimes with it is with background history of LBBB pattern. Okay, the next is 34-year-old male presented with syncope, BP not recordable. He has previous history of syncope. This looks very scary, right? So after this post cardioversions, there is a typical waves here. Can you able to appreciate? This is another clue. Wolf, Parkinson, White, WPW. Okay. So what exactly happens here? There will be like ECG, the sinus rhythm is there, but slurring of slow rise of initial portions of the QRS complexes. You can see it here. There is slow rise of initial portions of the QRS complexes with in the opposite directions of the major component of the QRS complex here. So due to this negatively deflected delta waves, this one, okay. So this is a prominent R waves in the V1 to V3. So remember, there will be discordant ST segment and T wave changes and pseudo infarction patterns. So remember, this is delta waves. This is called pre-excitation phase for WPW, and epsilon waves. This is called post-excitation phase for arrhythmogenic right ventricular dysplasia. Okay. So remember the two waves. One is delta waves. One is epsilon waves. These are very important for us to understand. Another one, there is a 5-year-old female with complaints of recurrent history of syncope. So can anyone appreciate here any changes? You can see this QT. Basically here, this is P waves. P, this is Q, R, S, T. So you can see the distance from QT, it is very, very prolonged. So it is called, yeah, easily you can see it here. Suppose this is a P waves. This is Q, R, S, T. So from QT prolonged. So this is one of the causes for cardiogenic syncope. So there are various drugs responsible for this cardiogenic syncope, like antiarrhythmic drugs like amiodarone, tricyclic antidepressants, many antibiotics like fluconazole, erythromycins, all like macrolides. Okay, metoclopramide and quinidine, haloperidol, and antipsychotics. Okay, these are all our medicines are responsible for have prolonged QTs, and some genetic factors like channelopathies, sodium or potassium channelopathies, myocardial diseases sometimes like myocardial infarctions, rheumatic heart disease, third degree heart block, sometimes have prolonged QTC syndrome, and certain electrolytes imbalances like low calcium, low potassium, and low magnesium. So also will have sometimes QTC prolongations. So, like I said, there is genetic disorders like channelopathy, sodium or potassiums. ECG evidence in QTC, if it is more than 440 milliseconds in males, that is significant. If it is more than 460 seconds in females, that is also significant. So, hallmark arrhythmias, it will lead into torsades de pointis. So, if it is if not able to correct, it will go into the torsades de pointis. So, treatment for this is magnesium sulfate. So, this is a primary presenting symptoms as syncope. This is one of the causes of death in young children, sudden cardiac death in young children. So there will be a long QTC. This is another patient, 60 years male, is having syncope. The systolic BP is only 70. This is the first ECGs. And after we are going to do the cardioversions, this is the second ECG you obtain. So like I can say the electrical conductions, there will be, you can have it here like RBB pattern is there with left anterior fascicular block, LAFB pattern. Okay. R waves, there will be a right ventral branch block superimposed on anterior Q waves and delayed R wave progressions. So STD changes, there will be diffuse ST depressions with reciprocal elevations in the AVR. You can see it here. The AVR is positive. Okay. There is ST elevations in the AVR. So what does it signify? When there is like AVR, there is a ST elevations. There are few things need to understood. First is check the lead placement. When many of the times ECG is done by the nursing staff or paramedics, they might have wrongly placed the lead. That is one of the cause for having ST elevations in AVR. Second most common cause, you can see it here, like diffuse subendocardial ischemia, like due to the oxygen supply hypoxia or no demand like mismatch, you'll have this elevations in the AVR. Second, third most common cause is any proximal LED occlusions like LMCA occlusions or proximal LED occlusions. Left main coronary like occlusions will have positive ST elevations in AVR. And if it signifies also triple vessel disease, sometimes if triple vessel disease is also there, you will have ST elevations in AVR. Like I said, there will be conduction, there will be abnormal conductions like RBB with LAB patterns. Okay. When you do a repeat ECGs, still the ST elevations are persistent in the AVR. So that also it signifies left main coronary artery occlusions, like I said, left proximal LED occlusions or severe triple vessel disease. And sometimes there will be diffuse subendocardial ischemia due to hypoxia or hypotensions like perfusions and demand mismatch will lead to have ST elevations in AVR. And if like you have done a CPR on a patient, immediately after obtaining the ROSC, you have done the ECG. So you will have a changes in the ST elevations in AVR. That is also signifies that when the patient immediately had a resuscitations from the cardiac arrest, ROSC has achieved, you can see these changes with the positive ST changes in the AVR. So the take home points here is history is very, very important. History, it is very crucial when identifying these high risk factors like Brugada syndromes, okay, WPW, white Parkinson white syndromes, okay, then channelopathies, what I've discussed, AVNRDs, okay, these are all classical ECGs. When you are seeing some patients, make sure you take a proper history, and systemic ECG interpretations will help us identifying the abnormalities. Many of the times it will give us many clues. Okay, so we should do a thorough like a reading of the ECGs with pertaining to the proper history taking, and don't forget our new tool that is called 2D echo machine, that is ultrasound. You should always make use of it. Do a proper like echo screening. You ask your seniors to help you out if you have any doubts, because that will give us many clues. Because in emergency room, if you misdiagnose something, it will have a detrimental effect. So make sure when you are seeing some patient is having syncopal event, don't leave it like this. Don't assume that this could be having a case of vasovagal or cardiac sinus syndrome. So you properly take a history, any previous history or any death in the families, any cardiac background previously, any underwent any procedures before. All these three risks need to be taken care very seriously and document everything and make use of your ultrasound machine so that it can give us many clues. This is a new adjunct. Every emergency room is having nowadays. It's a 2D ultrasound machine. So make use of your cardiac thing, focus. Okay, and you try to read the ECGs. Always take the help from the cardiologist so that you will not miss all these high voltage, like high chances of structural changes or any abnormalities like in posterior oval MIs or any AV kind of symptoms, epsilon waves, delta waves. These all these things you need to be familiar with the ECGs. Okay. So I would like to inform one like upcoming events we are having in our emergency for Yashoda Secunderabad unit. So we are going to conduct a program like CME on obstetrics, gynecology and paramedics. It is going to happen in February, second week, like 13 or 14th of February. So requesting all the emergency physicians or and pediatrics residents to participate. We'll be having high impact scientific sessions here. So we'll be having faculties from all over India, like from CMC Vellore, from AIMS, and we'll be discussing some rare, very real case discussions with practical solutions. We'll be having work sessions as well. So it will give us a very focus on reducing maternal mortality and child mortality and morbidity. So it will be a gonna be very good like outcome for CMAs. All the people are requested to participate and enroll themselves for this CMAs. Thank you so much for the patient listening. If you have any doubts, you can always raise. I'll be there to answer all those. Thank you.
Thank you, Mishra sir, for the excellent and practical talk. The way you simplified ECG interpretation in Syncope and highlighted high-risk pattern was extremely valuable and relevant to the day-to-day emergency practice. I'm sure all the participants will take away important learning points that will improve patient safety and clinical outcomes. Thank you for all the participants, and thank you Yashoda Hospitals for bringing such high quality academic sessions every week. Sir, we'll wait for a couple of minutes to,
Okay.
if anyone have any questions, they can ask. Okay, all the participants, if you have any questions, you can ask directly here or you can place in the chat box. Okay, sir, I think everyone is clear with your topic. So with this, we'll conclude this session.
Thank you. Thank you so much, Madhu. And thank you so much for the organizations of this webinar, for giving me this platform to discuss. And thank you, management of Yashoda Group, so that we can able to deliver our lectures on every Friday. Thank you so much. Thank you, everyone.